Hi everyone, I'm Eli Peckham and I'm going to present to you carpal tunnel syndrome case study. So first, a little basic anatomy of the carpal tunnel. The median nerve and 9 tendons run through. The 9 tendons, one tendon is thumb flexion, so the flexor pollicis is longest, and the other 4 provide finger flexion, and then supplementary wrist flexion as well. The median nerve supplies the thumb and first and second fingers. And then, so the posterior border of the carpal tunnel is the carpal bones. And you can see on the diagram, I put in those 4 that were in the picture, which ones they are. And then, so the transverse carpal ligament is what's injured, and it's due to thickening and scarring of connective tissue. And so that compresses the nerve, and it's called a compression neuropathy. And so again, median nerve supplies the thumb, first and second fingers for sensory and motor function. The muscular function, finger and wrist flexion, thumb flexion. And the transverse carpal ligament is structural. It's the anterior border of the carpal tunnel. And so how can this injury happen? There's 3 general types of ways that can happen, such as repetitive motion, like active and resistive wrist flexion, such as sports like bowling and golf. There's passive wrist extensions like football. They're trying to block somebody, a little bit eccentric component to that eccentric wrist flexion. Then there's also outside forces. So there's going to be repetitive, brief, large forces, such as doing repetitive handsprings in gymnasts and tumbling. And then there's going to be acute large forces, such as a push or a vault. And then fall on an outstretched hand. And then it could be a small force present for a long period of time, such as maintaining a handstand or doing rings and bench gymnastics. And there's also extended periods of wrist flexion or extension where they're in a position and they're not able to get out of it, such as grasping, such as on uneven bars, typing on a computer, and then prolonged hyperextension, such as men's palm wars. And so the importance, mostly carpal tunnel syndrome is known as an occupational injury. However, there is a sport aspect to it. There's not a whole lot of research on the prevalence and about what percentage of athletes get carpal tunnel syndrome. However, it's present in about 2 to 6% of the general population, depending on what source you get the information from. And so it applies to sport, particularly in gymnastics, bowling, golf, tennis, for the mechanisms that I previously mentioned. The symptoms are debilitating, which is the biggest thing. So there's going to be a lack of grip strength, lack of range of motion. There's going to be pain, numbness, tingling, burning sensations in the thumb and first 2 fingers, and then just general functional impairment. So the athlete or patient can't use their hand as well as they normally would. And so that affects their ADL, such as cooking, talking on the phone, typing, writing an essay, taking notes. And then, so the median nerve is compressed along with the tendons. So the patient in question, female gymnast, performing at the collegiate level, 20 years of age. They have a history of 2 wrist sprains, 1 in each wrist, both grade 1, both fully recovered. So they presented with symptoms, joint pain in the anterior wrist, weakness in grip strength and wrist flexion, 3 out of 5 manual muscle tests, numbness in thumb and index finger, and so this affects their functionality, particularly in uneven bars and floor routine. Attempted interventions were wrist taping, ultrasound, non-thermal, electrical stimulation, NSAIDs, and splinting at night. Splinting at night is a very common and commonly accepted form of treatment for carpal tunnel syndrome. So an athletic trainer can recognize carpal tunnel syndrome. And so they're looking at the locality of symptoms. It's in the hand, not in the elbow or up the shoulder. The mechanism also plays a part. There's going to be a look at the lack of strength, lack of range of motion. Positive special tests are include Phelan's test and reverse Phelan's test, along with Tinel sign. And some special tests that you can use to rule out other injuries, such as thoracic outlet compression syndrome that would cause neurological impairment. You can rule out fracture and dislocation, particularly of the lunate bone. There's Adson's and Allen's maneuver, and then Roos test is also for TOPS. And so there's other ways to diagnose this as well. So the X-ray is obviously going to rule out fracture and dislocation of the carpal bones. And then electromyography, it's a test where they send an impulse or an action potential above the wrist, and so they send it through the carpal tunnel, and it'll come out on the index finger, and so they can measure the time delay or the latency with that. And then so there's going to be varying degrees of carpal tunnel syndrome based on that test. And so that's usually the factor about whether an athlete or a patient would need to get surgery. third carpal tunnel syndrome. So whether surgery is going to be necessary or not, someone to read the test, the EMG test, and figure out what's impaired and what are the implications of their neuropathy. And other things to take into consideration before deciding on surgery is the patient's needs, their level of activity, and what they can be doing with their hands in the future. And so this patient obviously still high level of activity. She still has a collegiate gymnastics career ahead of her. There's going to be ADL requirements such as school, so typing, writing notes, talking on the phone, just using the phone, texting. And then there's sport requirements as well for gymnastics. So there's two types of surgical interventions. There's open release, which is just an incision, and they cut the transverse carpal ligament and release it. And then the other way is endoscopic release, so it's the use of a camera to guide the procedure. However, most surgeons prefer open release, mainly because of the benefits, the short operation time. It only takes about 7 minutes after prep work to do this release. And it's a pretty simple procedure, relatively speaking. There's generally greater symptom relief and a lower complication rate. There's lower risk of other things happening, of damage to other tissues. And so there's going to be risk some initial scar tenderness, initial grip weakness. However, there are also benefits to endoscopic release as well. So there's going to be less dissection of the subcutaneous tissue. There's going to be less scar tenderness, and generally an earlier return to work and activities of daily living. But then there's also the complications of that type of surgery, which are incomplete release of the transverse carpal ligament. There can be nerve or arterial injury, there can be hematoma, or flexor tendon injury. And then, so this athlete had open release surgery. And so, in terms of rehab, we want to reduce the symptoms. We want to regain full range of motion, strength. We want to return to weight bearing in their wrist, because that's an important part of gymnastics. We want to return full balance and proprioception, again, very important in gymnastics. And then return to functionality, so it must be functional sport specific exercise before they can return to sport. And then we'll do a psych. They need to restore confidence and trust in their body. And so this is going to happen 6 weeks post-operation. They'll be back. And then, so in order to progress to more advanced exercises and more advanced progressions, they must demonstrate proficiency with the exercise. They must be pain and symptom-free. They must have satisfactory neuromuscular control, proprioception, balance while they do the exercise, and do them with good form. So symptom reduction, kind of just some really simple ways that we normally do it in TC. Ice, laser, heat pack for DOMS, joint mobs, grade 1 initially for pain management, and then grade 3 for accessory range of motion. And then Graston to help reduce scar tissue buildup, and then scar mobs once the incision is healed to strengthen the integrity of the scar. And so the exercise I'm going to show you, they're not going to be an exhaustive list, just some general parameters and days of the week that an athlete might be doing this type of rehab. These are specific to this athlete. So there's wrist stretches, can increase range of motion, finger opposition, that's touching the tips of fingers to your thumb, and then thumb opposition, which is kind of the opposite, where your thumb is the main instigator of the motion. There's flexor tendon glides are great for reducing scar tissue, and so there's ways you can do that. So you basically just slide your, it looks like that kind of. There's two different types. And then joint modes also increase range of motion. And then in order to return to their full strength, there's going to be a lot of different stuff we do for this. So we want to increase strength at the, so the injury occurs at the wrist, but we want to get the joints above and below. So we want to include fingers, thumb, elbow, and shoulder as well. And so we can do that through grip exercise, do body blade stabilization, where they have to stabilize their wrist and elbow while they're moving their shoulder in a controlled manner. You want to work the elbow a little bit, get some flexion, extension, strength. Upper body bike for muscular endurance. And then resisted thumb opposition is big important, especially in ADLs. And that needs to be fully recovered and strengthened. So there can be push-up progression, and then PNF, slow reversal for functional range of motion and strength. And so to return the athlete to weight bearing on their wrist, it's going to be important that we don't do it all right away, and that we start partial, then go to full, then go to multiple times body weight or explosive plyometric type activity. And then so some examples of partial range of motion. You can do bird dog, or partial weight bearing. You can do bird dog, push-up progression, plank progression. So putty weight bearing is it's kind of like rolling out a little bit. Like if you have a plantar fascia injury, so you kind of just roll out your wrist and put a little bit of weight, a little bit of body weight leaning into it. Back bends, very functional for gymnastics. Pikes. And then handstand progression is kind of the biggest one. So you can start on the forearm, where there's not going to be a whole lot of weight put on and pressure put on the wrist, and you can move to wall. So they can use the wall to stabilize themselves, and they don't have to have so much stabilization at the wrist. And then ultimately, our goal is to get them back to a freestanding handstand, which is full weight bearing on the wrist. And then, in order to increase the amount of force put on the wrist, you can do plyometric type stuff like clap push-ups, and then more functional activities such as cartwheels and back handsprings, where more times body weight is going to be put on the wrist. And then in order to return the athlete to full balance and proprioception, there's different stuff we can do, such as dead bugs, bridging, around the World Cup pickups on an unstable surface, single leg stands with ball toss or eyes closed. PNF patterns, also very good for balance, for proprioception. And then handstand progression, I already talked about, and push-up progression. And then in order to return the athlete to functionality, ADLs are going to be really important. So a lot of the focus has to be on the hand as well. And so that can be done in various different ways. Core strength is very important in gymnastics. So plank progression, bridging, dead bugs, and pikes, all are good for that. And then they need to have good balance and also good proprioception, because gymnastics is a lot about form and technique. And so in order to increase that, we can do PNF, round the World Cup, single leg stands, planks, and handstands. And then so more sport specific, handstands, cartwheels, and back handsprings. And then a little bit of psych rehab. So the goal is we want the athlete to gain trust in the body and trust the rehab so that they can return to sport with full functionality and not have any misconceptions about having to go too easy or whatever. And then so we want to return them to sport at pre-injury levels, both physically and psychologically. And so to do that, we can use imagery, relaxation, yoga, meditation, Tai Chi, and then functional progression is the best way to get them confident and to have them do exercises that they would normally do while performing gymnastics. And then so in order to return this athlete to sport, there's going to be 5 criteria that we need. So they need to perform all weight-bearing activities with no pain or neurological symptoms. Because if we don't do that, then we're back to where we started, right? They're still going to be disabled. And so we want full strength in the hand, wrist, and the forearm. Full functional capacity. They must be able to do handstands, cartwheels, and back handsprings, and be able to put a lot of weight on their wrist with no symptoms. Then they also need to be functional up here as well, mentally. And then fully minimize risk of aggravation or further injury. And then fully minimize risk of permanent disability. So in a sport like gymnastics, where there's a lot of pressure put on the wrist, there's still going to be a risk, but we want to minimize it as much as we can completely, so that in the future they won't have that issue. Carpal tunnel syndrome is a lot more common in people ages 40 to 60, and so we want to minimize the risk of developing that within that time frame. And then so in conclusion, carpal tunnel syndrome is important. It happens in sport. And the symptoms are debilitating. It definitely affects their ADLs, it affects their everyday life, and it affects their performance. And so there's multiple ways that carpal tunnel syndrome can develop, such as outside forces and then repeated motions. And then so the patient still has their gymnastics career plus the rest of their life ahead of them. And so that's some stuff we have to consider when we do our rehab. And then so in order to diagnose, there's manual tests and also electromyography are great ways to diagnose carpal tunnel syndrome. And so rehab, we just want to reduce the symptoms from the surgery, make sure that there's scar healing and tissue healing. And then regain range of motion, strength, weight bearing ability, functional capacity, balance, proprioception, ADLs, and confidence. And then ultimately return this athlete to sport with no symptoms. There's my references.
What's the likelihood of this happening, like the symptoms developing again after the surgery and rehab takes place and they return to full activity?
I Athletically, not very likely. Some people are generally more prone to develop carpal tunnel syndrome, and that can be because of what they do for work, what they do, how they sleep, stuff like that. And so even if this athlete doesn't develop it in sport, they can also develop it later in life, just in everyday activities. Because gymnastics isn't going to be their whole life, and so there's other aspects to developing that. And so it's kind of hard to research that and find the prevalence of how that happens. Marcus?
Do they how do they cut the transverse carpal tendon, or ligament? Do they cut it longitudinally or transverse?
I don't remember. I want to say it's this way.
Okay.
Does carpal tunnel syndrome in athletes usually happen just in one hand, or is it usually
It depends on the sport.
like for like a gymnast?
Like a gymnast, generally it would be both. Bowling, like I mentioned, that would kind of be one. Golf would be, it's a one-sided motion, so generally it would develop in one. But if it's an occupational injury, then most likely it'll develop both. Caleb?
Did you make your athlete, when they're returning to play, in order to prevent symptoms from reoccurring, did you have them put any other type of bracing on top of the normal braces and grips they use for bars and such for like more support, or was it just a use what you have sort of deal?
So they gymnasts generally use a brace anyways when they perform. But so in terms of that, we didn't do any bracing or splinting during rehab. However, I did have the athletes splint at night. And then initially right after surgery, they would be in a splint for anything that's not light activity. So light activity would be like taking care of your body, your hygiene, cooking, stuff like that. Just to ensure that healing takes place.
Are there any